Okay, it's 1 minute past. I think we will start. Hello, everybody. My name is Peter Roeleveld. Welcome to this webinar, EuroELSO. It's a pediatrics special webinar. It's a pleasure to have you all here, and it's an even bigger pleasure to announce my co-panelists and our speakers. Just before we do that, before we start talking about Pediatric ECPR, I want to ask you to post questions in the Q&A, and then the panelists will forward them to the speakers at the end of the session. Okay, so now we can start. First, I would like to introduce Malaika Mendonca, who's a pediatric intensivist from Bern in Switzerland, and my colleague Tim Thiruchelvam from Great Ormond Street in London, and they will co-host this session today and introduce the other speakers. I hope you have a fantastic webinar.
Yeah, good afternoon. A very warm welcome also from me. I'm excited to be here today with all of you, because pediatric ECPR is becoming more and more a topic. It is used and executed in many hospitals, and so we from EuroELSO thought it is a good idea to start off with the ECPR education. And we will start first with the first speaker, Dr. Mark Davidson. He is CICU, PICU lead in Glasgow, and he will start with the pediatric ECPR history. Thank you. Mark, the floor is yours.
Thanks very much. Hopefully you can see the slide online. Just 2 seconds, I'll just share that. There we go. Right. So yeah, Malaika, Pete, Tim, thanks very much, and thanks for co-hosting this webinar. It's really exciting to really kick off the webinar series and think through where we're going. And I think pediatric ECPR is such an important topic. I have the good fortune to lead the pediatric ECPR working group within EuroELSO, and I think this is something that's really come to significant prominence over the last few years, and we've learned an awful lot from our adult colleagues who are doing a huge amount more ECPR than us. The first adult reports of ECPR were back in 1976, and the first pediatric published report was in 1992, some significant time ago. And I think things have in some ways moved on, in some ways they haven't. We're all facing significant challenges across our ECMO programs, our cardiac programs. We're under the spotlight from social media, from families, from our organizations, government, politicians, and so on as well. And ECMO really is, we know it's working at the highest end acuity. It's a low frequency event, but it's such an essential part of all our programs. And ECPR is really the pinnacle of that. So I suppose this working group and the focus of EuroELSO as a whole is about how we can improve education, improve what we do across the ECMO community. And I think there's an awful lot we can do about pediatric ECPR, because there's a lot of questions that we don't know the answers to. And I think some of the topics that Maura, who's very kindly speaking after me, will bring up as a very experienced ECMO specialist, and Ajay will talk about the challenges and questions from us all across the ECMO community. So I think there's real significant challenges, but there's lots of steps that we can make in the right direction and help us change where we are, change where we're going. So I suppose just to be clear, I've got no disclosures apart from I'm I suppose an ECMO zealot, and I think we can keep doing better, I suppose is my disclosure. I think we've not fixed this. So what's the plan? What we're going to do over the next hour or so? We're going to talk a little bit of background. That's my job. I aim to set the scene. We're going to look at, I think, an area that is often unseen and look at ECPR through the eyes of an ECMO specialist, so with Maura. And then Ajay is going to talk us through the results of the EuroELSO ECPR survey and the questions for all of us as a wider community. So what is ECPR? Well, there's very clear definitions from the Maastricht EuroELSO meeting, and that led to a position paper published by Steve Conrad and many others, and Malaika's in there as well. It's very clear that ECPR, as per the ELSO definitions, is ECMO that's either instituted with ongoing chest compressions or within 20 minutes of return of spontaneous circulation. Now, that last bit is really, really important to make sure that we get the definition right before we think about where we go. So it's really, really important that we understand the very clear definitions, not just for ECPR, but the other areas that are highlighted in this really important paper. And I think first thing would be, I would ask people to go away and look at this paper, read this paper, study it, and think how we use and how we input our data to ELSO, or how we review it either locally or nationally or internationally. So please go away and look at that paper as a piece of homework. We can look at the ELSO guidelines, which were published back in 21. So realistically, they're probably out of date now. So we should, and we're, as an ECPR working group, our Pediatric ECPR working group, we're linking in with the likes of Giles and Graham and Anne-Marie and many others to think about how we can update these ECPR guidelines and improve practice and direct us all, because I think we all think we do okay. I don't think any of us have all the answers. Now, is ECPR, are we good at it? How do we get on compared to our adult colleagues? Well, we can see from this this chart, which is data I pulled off the ELSO website just 4 days ago. So it's hot off the press, it's current, and it shows that the green bars, neonatal ECPR, the survival has stayed round about 22–23%. This is international data over the last 5 years. Pediatric, as in more than a month old patients, the survival has dropped. So we've gone from 34% to 26%. So are we doing something wrong? Are we using ECPR in different patients? What are we doing? Maybe we're putting the wrong patients on. Maybe we're thinking through the wrong decisions. And I suppose that's part of the focus of the ECPR survey across EuroELSO and elsewhere across the globe, is to start asking those questions, because I think we need to ask them across our network. We're very clear that as that survival has dropped, where are we going? What are we doing? And what can we learn from our adult colleagues? Now, we're not all going to cannulate people in the Louvre because it's a nice photo shot, but we need to think what we can learn from our adult colleagues who are doing an awful lot more ECPR. Maybe we can learn from the big kids. And if we look at the amount of ECPR, so this is runs per annum over the same period, the last 4 years, just taken off the ELSO database, the pediatric numbers stay around about the same. So around about 500 to 550 cases per annum over the last 5 years. Neonatal ECPR, very small volumes. But look at the trend in the adult papers, that those numbers are going up and up and up. And many centres have very efficient adult ECPR programs, both in hospital and out of hospital. So what can we learn from these big kids? Now, there's lots of evidence out there, and there's a lot more research that's going on now. I think we can mirror this in the pediatric field by working together, by thinking through what questions we want to answer and asking them in a planned fashion. So there's lots of different studies looking at the benefits of ECPR in our adult colleagues, what temperature we should go for. There's also lots of different meetings out there to start talking about it. And what we've done with an ECPR working group is try to develop multiple angles to this. So think about how we can learn and develop simulation strategies. So Mariana, one of Tim's colleagues in Gosh, is helping to develop that. We've rolled that out through the ECPR school and working with our adult colleagues. We've had significant focus on ECPR within the EuroELSO congresses, and next year's meeting in Milan is going to be no different, where we have a distinct stream focusing on pediatric ECPR. And I would encourage everyone to come to Milan, take part in that. Let's drive that forward, because we know that ECPR is a really high pressure environment, and actually we need to think ahead and plan as to how we manage our patient and what are the next steps. How long is too long from CPR before you call the ECMO team? When do you call the ECMO team? What is the evidence for everything that we do? Now, I would suggest in the pediatric field, there's not a lot of evidence to back this up or back up what we're doing as individual centres. There's no big studies. There's expert consensus as per the ELSO guidance, but there's no great research pathway that's led us to do the right thing. So what are our pathways? What things do we think of when we're putting patients on ECMO? So we can think about drugs. How often should we give adrenaline? There's very clear evidence from a recent paper in 23 in resuscitation that actually the more adrenaline doses you give, it's associated with poorer outcomes. Maybe we should just be limiting the number of adrenaline doses in an ongoing CPR before we go on ECMO to limit the significant sequelae of recurrent doses of adrenaline on our cardiac myocytes and the rest of our end organ perfusion. When we're going on, what prime do we go on at? What do we go on with, a blood prime, clear prime? What is the right clear prime? We don't know that. There was some guidance as to what it should be, but we don't have the right answers. What temperature do we go at? This is a question that's a bit like steroids and digoxin. It goes in and out of fashion. There's quite clear evidence that maybe correlating from animal studies that maybe we just don't cool quick enough, or we don't cool for long enough. But we really do not know the evidence as to what we should be doing in pediatric ECPR. There's some interesting work coming from Alice Hutton and the Paris team looking at, going back to the future, using liquid ventilation to rapidly cool the patients. And in animal models, that seems to have a positive effect. Are we going to see that through our patients or through adult patients? I don't know. I think that'll be a significant challenge. How do we manage carbon dioxide across our centres? We need to think about that rapid change in CO2 in our patients when we suddenly go on ECMO? How do we limit the impact of that? Do we all think about that when we go on in an ECPR, or in fact any patient setting? How do we manage that transition to an ECMO circuit and minimise the risk of brain injury from an acute change in CO2? Finally, what oxygen levels do we go on at? The more I think about this, I think hyperoxia is bad. We're very clear that hyperoxia is bad for you, and I think less is more in so many fashions or so many aspects of what we do. So maybe we should challenge the stigma or dogma that we should be going on at an FiO2 of 40% or 60%. Maybe it should be air. We don't know. And I suppose this is part of this discussion, is to ask us all those questions and get a steer on where we go next. At the end of the day, prevention is better than cure. So if we can avoid patients having a cardiac arrest and needing to go on in an ECPR situation, how can we pick those patients up? How can we manage the many systems we've got? How can we train our staff better to pick those patients up and manage them and step in a timely fashion, whether that be by avoiding ECMO altogether or by going on ECMO in a planned fashion? I think Nelson Mandela said many fantastic things, but this really hit home to me when thinking about pediatric ECPR, because we don't know what the outcomes are in our patients. And I think we should think that our choices should reflect our hopes and not our fears. But we need to know when to stop and when to stop putting patients through things that aren't going to have a positive benefit. But I think we need to chase those hopes and make those things work better. As an ECPR working group, we've published a review of the current situation earlier on this year with many of the people who are speaking here today. Go and have a look at that. This is the first step in an ongoing narrative, and I'd encourage anyone out there to come and join the Pediatric ECPR working group. Here's a link, so you can take a snapshot of the QR code here. It'll take you to the EuroELSO website, and all colleagues are welcome to join not just the Pediatric ECPR working group. There's several other working groups out there. Please do join in. This is about enhancing education and developing the care that we give across all our ECMO communities across the globe. I think we need to work together. We need to collaborate. And I suppose I would ask that we keep doing that. And I've hopefully set the scene, and I'm really looking forward to hearing what the rest of the panelists say. Thank you very much.
Thanks a lot, Mark. That's a fantastic overview, and I think it does set the scene very well, both for the practice that most of us recognise in some form or other, and the need for consistency or at least a minimum standard there, but also the knowledge gaps that we have that we need to work on that may, some will be in tandem with the adults and some of it won't be, some of it will be different in the paediatric population. So I'm sure that's going to generate some discussion. But I'd like to introduce Maura O'Callaghan, who is my favourite colleague, who is the lead ECMO specialist at Great Ormond Street. She's the cornerstone of the ECMO service here. She takes the pressure off all of us. She tries to make the rest of us look good and also do better. So Maura's going to speak to us next.
Well, I'm not sure what I can say after that, but thanks a million, Tim. So thank you first to you, Tim, for that introduction, to EuroELSO for the invitation. And my name's Maura, as he just said. I'm the lead nurse for ECMO at Great Ormond Street in London. And over the next 10 minutes or so, I just want to give you ECPR through the eyes of an ECMO specialist nurse. I put that I have no disclosures except that I am an ECMO specialist nurse, and for this presentation I am representing ECMO specialists, hopefully from around the world. So thank you very much, Mark, for this paper. That's brilliant, and I won't give you any homework because Mark's already given it to you. But what does the ECMO specialist nurse want to know? We do want to know what ECPR is. And we need to know that that is the initiation of ECMO during chest compressions or within 20 minutes of ROSC. Where can ECPR happen? Anywhere. So it can be anywhere within the hospital. It can be a post-op cardiac patient that can be newly operated on with an open chest, intubated and ventilated, or a child that has their chest closed and is ready for discharge home. It can be an out-of-hospital cardiac arrest. And so where the initiation of ECMO happens can happen in lots of different places, but you want that to be systematic, safe, so that that child goes on to ECMO in the best way forward. We want to know what outcomes are. And where can we get those outcomes from? Well, we've obviously got the extracorporeal life support organisation. We've got our own institutional data, and we, rather than just mortality, we also want to know what the morbidity is and what's the neurological outcomes long term. So this is data from 2023, so apologies that it's not quite as up to date, but this was the ELSO data that came out with Pediatric ECPR and Neonatal ECPR survival to discharge, and it was 40 and 44% respectively. There is Get With guidelines, and this was where two big registries came together. So it's the Resuscitation Registry and the Extracorporeal Life Support Organisation. And lo and behold, what did they come up with is that they want that children, the longer that they have CPR, is the worse their outcomes are. So we need to think about candidacy, because most children will have CPR and will recover. But what are the groups that need ECPR in the middle, and how do we define them? So there's two ways to go. You can either go on electively or following CPR or ECPR. And I know that Mark, thank you very much, said that ECPR is growing worldwide. I think from an ECMO specialist point of view, we would rather not see any ECPR at all. And we would rather that children go on electively onto ECMO before they arrest, if that was at all possible. So to keep the numbers low rather than them growing. So again, where did this happen? It can happen in theatres where there's difficulty coming off of cardiopulmonary bypass. And that can be very difficult for the surgical team. They've invested so heavily in this patient that are they as objective as they need to be when that child is coming off a bypass? Or in CICU, are we really watching the signs of low SVO2, low lactate and higher inotropic support? And should we be raising the question of considering elective ECMO? So what do we need to be able to do that? So again, as ECMO specialists, we love guidelines. We love algorithms. We want these patients to be safe. We want to go on in a systematic way. And if things don't go right, we need something to go back to see how we could have made that journey to ECMO safer and for that child. We all want a gold standard service, don't we? So what would that look like? ECPR available 24/7, fully funded, with aims and objectives that are set and internationally recognised. Candidacy for ECPR is clearly identified. That we monitor outcomes and trends of those outcomes. Are they getting better? Are they getting worse? Because we can, should we be doing this? So we want to review our cases, and I think each centre can review those very individually and take learning from them. So what do we have here? Well, I'm representing the team, so I'll just let you know it is a brilliant team. We have our guidelines. We have training and education that includes simulation, and that includes rapid response or initiation of ECPR. We want to prevent ECPR if possible. What do we have at the bedside? We have what we call a watcher status. So that is where a child is considered a watcher and that they may deteriorate and that we may need ECMO support. So we're kind of alerted beforehand. But as we know in healthcare, the unexpected can always happen at any time, and being prepared for that. So these are just a little snip of our guidelines that basically take us through recognition of that low cardiac output state, that deteriorating child, to the decision to cannulate, to initiation of ECMO, and then post-cannulation care. As part of that guideline, we also have what the team's tasks are and the timings for different things. So everybody knows what they should be doing, where they should be standing, and how they are going to perform at the bedside. So to take you through a short case, this is a 3-kilo baby who had postnatal diagnosis of a moderate to severe aortic stenosis. They had, as with that diagnosis, they had pulmonary hypertension and they happened to have Klebsiella sepsis as well. They went through to surgery and they had an aortic valvotomy on cardiopulmonary bypass. The echo post-bypass showed a good repair. But what happened? Shortly after they arrived back on the cardiac intensive care unit, they had a short episode of hypertension with an SVO2 of about 43%. There was an increase in the noradrenaline and they had fluid resuscitation and everything resolved. But a few hours later, the arrest call went out. The child was now hypotensive with a mean blood pressure of 21, was bradycardic and had loss of cardiac output. CPR was initiated. This was a watcher child, and that was both external to begin with and then internal, and full resuscitation took place until that child was cannulated centrally onto ECMO. There was no return of ROSC. Following that, the child had a echo, and the aortic valve appeared intact, but there was LV distension and some spontaneous contrast, so an LA vent was added. Child had a couple of days on ECMO and was then decannulated. But I said to you earlier, what do we want as ECMO specialists? The same as the rest of the team. We want to know what the outcomes are and if there is any neuromorbidity. But the EEG showed that there was, even though there was a degree of cerebral dysfunction, it was carrying no particular adverse prognostic implications. The child had 2 ultrasound scans and they were both normal. So I spoke to the bedside team and said, what is it? What is your feedback? What went well with this case? And the first thing they said was, it happened during the day. And for us within our institution where we don't have ECPR 24/7, that day, night and the logistics of out of hours is important and makes a difference. They were really pleased with the allocation of the child coming out of theatre because it happened to be an ECMO specialist nurse that was allocated to the child, understood that watcher was ECMO watcher and was prepared for this child deteriorating. The whole procedure, ITU nurses, we like a bit of drama. So they were prepared, they got their drugs. But one of the things they said, and that hadn't really occurred to me, was that they said the nurse in charge, it was brilliant because she had the ability to step back and keep the environment safe and calm and manage the situation. And then they had a hot debrief. So I've told you about what went well. What could we have done better? And one of the things that they were talking about was this ECPR candidacy. And I said that we call that a watcher status. And watcher means that the child for us may have needed ECMO, but we haven't defined it down to the details of what cannulas would we use and what size cannulas would we use, and are they very close to the bed space. So what do ECMO specialists need? Support, 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 and lots of well-being. So the hot debrief occurred, and that occurs, it can be a few minutes if it's at the end of a shift, but it is important to have. We also have PEERS, which is an acronym for post-event evaluation, reflection and support. And that often happens maybe a few days later, maybe a week later, when people have had time to think through their thoughts and how they feel about the situation that they went through. We have weekly morbidity and mortality meetings, and actually that tells us a little bit more about the mechanics of maybe what went wrong and why this child's arrested. We have psychology support for the staff and chaplaincy, and obviously we will signpost them to whatever assistance and help that they need. And so there you are, in summary, we can learn how to develop a really good ECPR service or not if we include the ECMO specialist nurses' feedback. Thank you very much.
Thank you, Maura, for this excellent talk and sharing your experience and the view from the ECMO specialist and this interesting case, what you did. And I'm sure there will be a lot of questions, how you do things, how you work out things, what advice you can give. And I would still ask everybody to put the questions, please, in the chat, that we have a nice discussion at the end of the session. And now it's my pleasure to introduce my good friend Ajay. Ajay Desai is in the Royal Brompton Hospital in London, the lead of the ECMO team over there, and he has launched this survey, which is, he will tell us more about, but launched all around the world to all ECMO centers to see how we do ECPR at the moment, what is missing, what is lacking, and he will probably tell us what we should do in the future. Thank you, Ajay.
Thank you, Malaika. Thank you very much for the generous introduction. Can you see my screen? Okay, thank you. So good afternoon, everyone. I'm going to take you through the EuroELSO Pediatric ECPR survey. I have to acknowledge that this has been a real team effort from everyone you see on the screen, Tim, Maura, Mark, with excellent comments and suggestions from Pete and Malaika and other steering committee members within EuroELSO as well as also. No disclosures from my side, except that I just want to learn more and help patients. So the background is that I'm not going into detail about the definition of ECPR. We have been through this already. The key message is that ECPR is a complex resuscitation intervention that requires highly enhanced resources, be it human resources, technology, as well as monitoring. And also the amount of interprofessional teamwork that is required for a successful ECPR is enormous. So a couple of years ago, when we all met, we came up with the hypothesis that variations in systems exist, as well as clinical practice between ECMO centers that offer ECPR service for pediatric patients. When there are variations in systems and clinical practice, you may imagine this may have an impact on patient outcomes. So we aim to evaluate these variations within ECMO centers that offer neonatal and pediatric ECPR. We used a bespoke online survey. We conceived this project at the Prague ECPR conference in October 2022. Over the next year, we sought feedback from EuroELSO and also steering committee members. And we launched our survey in the Prague ECPR conference in 2023. Survey questionnaires were shared via emails as well as social media. So we used, we adapted this well-established ALCOR consensus at STEAM registry template for in-hospital cardiac arrest. How the journey of an ECPR could be considered in different settings. These are like a chain of events. So the following segments were used. One is, do all the ECMO centers have consistency in understanding the very definition itself? And we also designed questionnaire to evaluate the system and how the ECPR team is dispatched. How do centers ensure CPR efficacy? And we also looked at variations in practice, if there were any, regarding post-resuscitation care, and were there any follow-up arrangements. We did not cover patient outcomes in this survey. So a total of 53 ECMO centers took part, all 5 also chapters represented. So I think that's a very positive start. People were very engaged. Majority of respondents from Europe, followed by Asia Pacific also, then followed by North America. So as far as understanding the ECPR definition, this was a very good news. All centers followed the same definition. This is important because we all fill in also data, so it is better that we all understand the definition. Regarding the system, you can see that nearly 50% ECMO centers were mixed PICUs. 34 centers were dedicated cardiac ICU, and general PICU 7.5%. There was one neonatal ICU participated. Then here you can see that very broadly the amount of ECMO activity was similar, 1/3 between 0 to 15 ECMO runs a year, and another 1/3 between 15 to 30, and 25% had a high volume ECMO center. There was one center which had 90 ECMO runs in the year 2023. Regarding how many of those ECMO runs there were ECPR. So less than 5 ECPR, majority of the centers belong to that category. You can see that 9% of centers had 11 to 20 ECPRs a year. So this should trigger some review in the sense why there are so many ECPRs. And surprisingly, 10 centers had not yet registered with EuroELSO. 50% of centers were co-located with adult ECMO center. As Mark highlighted in his talk, having co-location with adults comes with its unique advantages as well. There were 41 centers who had pediatric trauma service as well. Nearly 68% of centers, that is 36, had a place system to deliver 24/7 ECPR. As Maura was alluding to, between out of hours cardiac arrest, out of hospital cardiac arrest, 75% did not offer out of hospital cardiac arrest. Only 12 centers out of 53 had the ability to launch out of hospital cardiac arrest ECPR. Again, 29 centers had a formal ECPR training program. This was interesting, as alluded to by previous speakers, how ECPR system was activated. Only 4 centers said that they activate both CPR and ECPR simultaneously. Majority of the centers initiated CPR first, and then if required, they went for ECPR. By and large, within 10 minutes, all centers activated ECPR call. So we also wanted to ask regarding the team composition. Our question was, does your institution have all team members required to deliver ECPR on site 24/7? Again, no surprises here. 35 centers, they answered no. Majority centers, perfusion and the surgeon, they were the limiting staff members. Then we also wanted to know about primed circuit. Do centers keep them available 24/7? Here is the interesting data. 11 centers said that they would keep a clear prime for up to a month. 9 centers, they said up to 60 days. There was one center who responded that they would be keeping a primed circuit ready to go for 3 months. And again, as you may recall, there was issue with the CardioHelp supply. But during that time, a CardioHelp came with a 6-month expiry. So a dry setup was equivalent to the expiry date. And then circuit clear prime plasma light had 65 days expiry. This is an interesting comment from a perfusionist. It's often a mistake to assume that the circuit is the same time limiting factor to rapidly deploy ECMO. Often there are other factors which are more important. A simple back to basics circuit can be rapidly assembled and primed as required. Maura just highlighted about team debrief, both whether it is hot debrief or cold debrief. You can see that nearly 40% of ECMO centers did not hold a team debrief within 24-48 hours. Then whether there was MDT review, case review after each ECPR case, around 9% did not follow that practice. But by and large, teams had a MDT approach. 36 ECMO centers had guideline on ECPR. Regarding the team dispatch, cardiac surgeon was the most common cannulator, followed by general surgeon. There were 9 centers where intensivist cannulated for ECPR and 7 by interventional cardiologist. Again, no surprises here. 51% of ECMO centers, they had crystalloid prime. And by and large, less than 10 kilograms, it was blood prime. More than 10 kilograms, it was crystalloid. Again, variations in staffing, which we have been through already, nights and weekends. There was, at least in 24 ECMO centers, there was variation in staffing. And as Maura highlighted, the outcomes can be different if a child needs an ECPR during the day hours or out of hours. We also wanted to look at the CPR efficacy. Again, no surprises here. End-tidal CO2 and arterial blood pressure, the most commonly used monitoring devices. Then we have NIAS, cerebral or other, abdominal or renal. Again, there is some recent shift towards how do we manage temperature during CPR. Most centers, they said they do not apply any cooling measures. There were 7 centers or 8 centers which said they would do ice packs on the head. Again, earlier alluded by our colleagues, how many doses of adrenaline, which Mark said no one knows. Again, you can see the distribution is fairly distributed, whether it is 2 cycles or 4 cycles until cannulation or variable. Here, we are not trying to say what is right, what is wrong. All we are trying to highlight is what is the baseline current practice, and then what is there to learn from here on. Regarding post-resus care, again, what's your oxygenation strategy? What's your blender FiO2? 22 ECMO centers would use 60 to 100% FiO2, and only 5 centers started with FiO2 in air. So there's a quite big variation here. Then we asked about patients' oxygenation targets. 9 centers said that they do not take any measures to avoid hyperoxemia, whereas 43 ECMO centers, they said they actively take measures to avoid patient hyperoxemia. So there is a shift in clinical practice towards starting with lower FiO2. What's the CO2 strategy? Again, you can see difference. How do we set the ECMO flow? So, or gas flow. So nearly equal proportion. Some started with half of the blood flow, whereas others went in with 1-to-1 sweep gas to blood flow ratio. Again, nearly 32 ECMO centers said that they would aim for gradual normalization, whereas 13 ECMO centers, they said they would correct the CO2 as soon as possible, rapid correction. Blood pressure management strategy, again, majority of the centers went for age-appropriate blood pressure. Couple of interesting comments. One is patient-based strategy, but clearly avoid hypertension on ECMO. If you can achieve higher flows, then you may lower your blood pressure target. Regarding the temperature management strategy, majority of the centers went for normothermia and avoid hyperthermia. So again, there is a shift towards normothermia and avoiding fever during this patient. But again, as Mark alluded earlier, we still don't know whether we don't rapidly cool them enough or whether the duration is inadequate. We don't have answers. Regarding neuromonitoring, again, no surprises, a variety of tools, majority being clinical, rest is EEG and ultrasound, CT as required. We asked if you had a guideline on organ donation. Again, 23 centers said yes. But everybody agreed that all patients should be discussed with organ donation team if you expect a poorer outcome. Then we asked about whether you have a system in place to offer end-of-life care or bereavement for families. 41 ECMO centers said yes. Regarding the follow-up, the question was straightforward. Do you have a formal neurodevelopmental program? 30 centers had no formal neurodevelopmental outcome program for ECPR survivors. I think this is a huge area needs to be focused. So from the survey, we can see that there is considerable variation amongst ECMO centers, both in the system within which they provide ECPR, as well as the clinical practice. Not all centers offering ECPR were registered with EuroELSO, but had similar understanding of ECPR definition. I think this is positive. More awareness and efforts are needed to incorporate organ donation and neurodevelopmental follow-up within ECPR program. I would like to briefly touch upon the next steps. I mean, we did the survey, so how do we move forward? So we can look at that in 2 or 3 segments. One is, what are the areas prior to cannulation we can think of? Definition, it's already ticked off. Registration, centers should be encouraged to register with EuroELSO for a variety of reasons. Maura talked about ECPR candidacy. If we improve the candidacy, the outcomes should be better. Delivering effective CPR, I think a lot of work needs to go on to this because probably this is the single most factor that impacts neurodevelopmental outcome. And also, are there any strategies to reduce time to cannulation? This is one of my favorite future projects. If you look at this paper by Harefield team in London, they have extensively studied how they can cut short the duration to cannulation. So they have achieved the time limit of 15 minutes from door to ECMO flow. Within that phase, they are able to cannulate consistently well. And I spoke to my colleague this morning, and they have cut it down to now 10 minutes. This is in adult population. I do understand you need to give more time for the pediatric ones. But this is an area which I think we all can focus on. Then pericannulation strategies, again, research and guidelines. At least every unit must have their own guideline or protocol. Key elements are temperature, oxygenation, avoiding hyperoxemia, and aiming for normocarbia. Then how do we do neuroprotection? So these are the areas to look for. Subsequent considerations, again, how do we prognosticate? How do we counsel parents? The impact of adverse neurological complications on morbidity and mortality is very high. We all know that. So how do we monitor organ function? How do we set up the follow-up program? And not to forget, there'll always be children who are unlikely to survive. So how do we initiate end-of-life discussion? Do we have that system in place? It shouldn't come as a surprise for parents. On the penultimate day, we disclose that your child is not going to survive. That shouldn't be the case. Then there are recent studies going on how to incorporate organ donation into ECPR scenario. And also, as Mark had highlighted, family support, religious background, I think that also needs to be looked at. I think this has been already shown. It's a very useful paper, and I would welcome any questions. Thank you very much.
Thank you very much, Ajay, for this interesting talk and sharing the results of this well-prepared survey. And I think, yeah, there's a lot of work to do. But I would like to now start with the questions the audience has asked in the chat so far. The first question was about that Maura told they wouldn't have 24/7 ECPR program. So what happens during off hours? Does the team come in emergently and place the patients on? And are the results as good as during the working days hours? And I think Tim and Maura, you can probably elaborate how it works in Great Ormond Street for the rest of the people who are interested in and probably want to set up a program when you don't have 24/7 in-house or something.
No. Thank you very much for the question. I think it's been very pedantic about we do resuscitate children onto ECMO, so providing ECPR, but what we wouldn't advertise is that we have an ECPR service because of the infrastructure. So our shortcomings, as you saw in Ajay's survey, was that we often don't have a perfusionist in-house. But what happens on the ward round is that perfusion would join that evening ward round. And if the consultant team or the ICU team were worried about any child, they would ask them to stay in. So that would be one thing. And then it would be that unexpected child that we haven't asked them to stay in for. And the surgeons, even though they might not be in-house, can get in very, very fast. They don't stay very far away. With the longer term outcomes with either in daylight hours or, in normal working hours or outside hours, I'm going to hand that over to Tim. Do you know that data, Tim?
Sorry, say that again, Maura.
So, just the outcomes for whether children that are resuscitated onto ECMO within working hours or outside working hours, have we got a feel within our own institution if there's a difference?
Not really. As you know, the infrastructure is the key. So the thing is, where we can predict or anticipate patients being sick, so either new admissions or highly high risk or technically difficult surgery that's at risk of deterioration, we would modify the team so that it is in-house. So we anticipate and make sure that we're ready to do that. So in fact, we can operate as though we have 24/7 cover. It's the unexpected ones that we may not be able to respond to as quickly. But even then, And I think this is the key, for most now. So there was a few questions from across the world, but I think the focus is on prevention, and having the team ready to do highly effective CPR before considering ECMO, or as well as considering ECMO, as well as the ability to pick endpoints whilst you're on ECMO and post-resuscitation care. So it's the whole system that comes into play, and it's that chain of survival that we're looking to improve along the way. So the ECMO is just a small but significant and complex component of it that we still don't really know how to deliver. And also your systems will be different. I think Ajay's already alluded to the adult services where you've got acute cardiogenic shock and you've got shock teams that will deal with ischemic heart disease. Whether that translates to neonatal post-operative cardiac surgery is difficult to know, but you may have to respond to all of it depending on your center. So I can see, I can see Mark's hands up.
Yeah. I suppose it's a question to everyone online about looking at your own system. I think Maura, Tim are absolutely right. What works in GOSH won't necessarily work for Pete and his team, or Ajay and his team, or Malaika and her team, or my team here. We had I'll maybe give you an interesting example. Like all hospitals, car parking is a nightmare. So where do your surgeons park when they're called in an emergency? Where do your perfusionists park and get access to the hospital quickly? What is the quickest way into your ICU? We've, I suppose, spent quite a lot of time looking at that journey. One, how do they get called? Do they know where to go? Being very clear which bed space they're going to. And it's very clear, bed space, 10, ECMO emergency, that's it, get here now. But actually when they're on their way in, I don't want the surgeon going too fast, getting stopped by the police, running a red light, being in an accident, or the perfusionist for that matter. I want them to come in safely, come in a calm situation whereby everything's under control. The perfusionist is dealing with the ECMO circuit, but how do they actually get into the hospital? So we did a piece of work following we had a very, quite rightly, officious car parking attendants who wouldn't let people park in a specific place. So, which added an extra 2 or 3 minutes to that journey, and it meant that staff were very flustered coming in by the time they got into ICU. So think about your staff's journey all the way to the bedside, from home to the bedside. Where do they park? Which door do they come in the hospital? Does their swipe card work? How can they get in the quickest way so that actually they can come in a seamless fashion, without having run red lights, without getting pulled over by the police, and get to the bedside to do what they're trained to do? So I would take it a step further back and look at that system from the phone call or before that to planning that patient goes on. So just maybe a plug to everyone to go away and look at their own systems, how their team get into the hospital, because I bet we don't have it all right.
Very well phrased, and a great example where to look and start off with for the if you set up an ECPR team, or if you have the ambitions like Ajay have to get it done under 15 minutes. I was wondering, Ajay, if I saw in your talk, when you looked at these adult patients, what is the most time-consuming factor? Is it the initiation or getting the team on, or is it the cannulation? And do you see any difference in pediatrics and adults there?
Yeah. Thank you, Malaika. I think what Mark just said, it just follows that pattern. Like you first map out from referral to cannulation, and each segment you look at it very critically. So when I spoke to Dr. Alex Rosenberg in Harefield this morning, so just to give you one example, that there is a very sick child coming in, and it's very likely to be ECPR scenario. The child can arrest any time, and you're going to cannulate. So you are ready with your team. At least until now, what used to happen is the child comes extremely sick on massive, you never know, the child might arrest any time, and then we hand over for 10 minutes. So can that handover be done during transport? So you don't have to waste time for handing over. So that's one area. And second one, this may be applying to adults, when you do a Seldinger technique and you start dilating the vessel, then they started reducing the number of dilatations. And now their latest model is no dilatation, just cannulation. So they have brought it down to 6 minutes from door to ECMO flow, 6 to 7 minutes. So we cannot apply everything, but there are certain elements where definitely we can adapt. The third thing here I highlighted was when the child is being prepped, the surgeon need not waste time in, while surgeon is washing hands, the ECMO nurse can drape, paint, keep everything ready. So you save minute by minute, and then you can reduce the time to cannulation.
Thank you. I think we have a few interesting questions in the chat already. So there is one from our friend Lakshmi, who is nicely joining us from the US, I guess. She's asking, what is the panel's opinion on pediatric ECPR for respiratory arrest, which is very different from ECPR in the CICU. Can you guys elaborate, or who is doing it? Is it done in your institutions?
Yeah, I mean, I may start, but others can join. Totally agree. There are two distinct pathologies, one cardiac and the other one respiratory. And if we look at the EuroELSO data set, until recently, I always used to think, every ECPR rescue had to be a VA ECMO. But I recently learned there are many instances where children have been rescued using VV ECMO. Perhaps those were the ones in that respiratory setting. So that was a new learning for me. The other thing I could say is perhaps maybe the prognosis could be better for respiratory arrest. It's hard to say. But again, the very question, why should we separate a cardiac arrest irrespective of the underlying etiology? Cardiac arrest is the end result of many things, whether it starts on the respiratory or non-respiratory causes. We shouldn't be differentiating too much. Cardiac ECMO versus respiratory ECMO. Sometimes you have both. Yeah, I would like.
I suppose one thing is like the mechanism of that arrest, and I think sort of in the early days, the way that I suppose I learned, or that ECPR was only for cardiac, and that the mechanism of arrest for respiratory was very different. And then, like all things, you learn more. And I think that you can emergently go on ECMO for a respiratory arrest, or respiratory cardiac arrest. And I think it will be outcomes that will tell us whether that's the right thing to do and whether there's a difference between the two groups.
I think that's a really interesting point, because for me, we don't have it very often, but we had one cardiac arrest in a child with an asthma, a cardiac arrest, and our team, we were just so used to go on VA ECMO, all was set up in the ECPR pathway to go on VA ECMO, so this child we put on VA ECMO, but probably Mark wants to comment on it too. Please go ahead, Mark.
Yes, I think it's Lakshmi is really, really interesting question, because I think if we look at the data, if we did a literature search, it would say it's not as good. So why are we doing it? But actually, I think we're asking the wrong question. We're not looking at it through the lens of our current setup. I think if we were to do that review, if we did a prospective study now, looking at utility of pediatric ECMO in a respiratory and secondary cardiac arrest, our outcomes would be much, much better than they were historically. I absolutely agree the data does not back that up, but that's looking at data that's 10 years old, 15 years old, 20 years old. I think if you go back in time, you look at how ECMO was managed at the beginning, a lot of it was VV, or patients were supported in cardiac failure with VV ECMO at the very beginning as well. So I think we have done, and we'll do it again in the future. Manage it in that situation. You want to never be in that situation, just like you never want to have your patient have a cardiac arrest, but that happens. So I think we should manage it in the same way. I'm not sure we should manage that any differently.
I'll just take another question from, there's a Robert It says, as the majority of us being present are not the actual cannulators, is there any way we can help our surgeons improve their cannulation speed, e.g. by creating e-learning? Go on, Mark. Go ahead.
I would, if we can get a surgeon to sit down and do their statutory mandatory training, that'd be fantastic. So I think it's a really, really good point, Robert. I think that's about multidisciplinary learning, and I suppose that's where Mariana, as part of the ECPR working group, is leading the simulation setup and making that a multidisciplinary real life. It needs to be as realistic for a surgeon as possible, and I think a lot of the utility of the cannulation mannequins now lend us to develop that, and we can do it very cheaply using, there's lots of stuff out there that shows it very easily and cheaply about surgeons actually being able to go through the process of cannulating a vessel. We're doing some work with looking at 3D printing vessels and hearts and so on, and I know other people are doing similar things. So I think we need to make it appeal to our surgeons by making it as realistic as possible, so they're doing the job that they're actually doing at that point in time. And I think there's a lot we can do to engage our surgical colleagues in that.
Absolutely agree with everything that you said, Mark. And I think it's training and education should be across the multidisciplinary team. And sometimes I think with ECMO surgeons can nearly get left on the side, as in, this is your bit, away you go, do your own thing. But I think pulling them into that team approach, because we deliver ECMO as a team, and we should learn and train as a team and support our surgical and perfusion personnel as well.
Yeah, Chris Harvey made an excellent point in the recent Prague conference, especially ECPR context and central cannulation. One of his tips was, we often see surgeons when they cannulate, they do spend some time suturing the cannula. It does take time. So what he says is, insert the cannula, start the flows, and then take your own time to suture. I think you can easily save 3 to 5 minutes there. I thought that was very useful tip.
So Ajay, on the back of the survey, one of the things is about next steps. So, was there anything you found particularly surprising from the survey, and what do you think each centre could do as an individual centre, and then we could do collectively to improve things, certainly within Europe and smaller centres outside the US?
Oh, you're muted, Ajay.
Yeah, sorry. We can look at it in two lenses. One is understanding your own system. As we all said, that every system is different. So there are some inherent strengths and inherent weaknesses. And where there are weaknesses, how do you mitigate them? I think Malaika already highlighted, if there is perfusion not on site, what are the things you can do to help that? Agreeing on candidacy or priming the circuit. So that is one part. The second is, I think, the way I have learned is, interact with people around the world. You know the systems, and for example, a conference like Prague ECPR conference, you get all experts there under one roof, and you try to understand what works for them. The things you may think, oh, this we can never do. Somebody's already doing it, and they are quite good at it. So knowledge sharing, Mark used, I think it was Maura, collaboration. I think that's the key. Collaborative education, training, research. In all forms, I think ECMO is a high resource program, so there's no point in reinventing the wheel. So we got to work together and minimize energy spent on each task.
Thank you so much. I think we, Peter, do we have still a few more minutes, or
I think we have a few more minutes. The participants, there are still about 100 people here, so
and a lot of questions coming on.
yeah,
Few
quite a
are
few questions,
also.
very interesting. So pick a few, and we'll give it a few more minutes, and then we need to round it off.
Thank you. So I think one is, of course, setting up a program, how to maintain it, how to improve it. But a lot of questions are coming on also about candidacy. How do we pick candidates? One question from the audience, for example, is would the pedalists offer ECPR to a septic child in the emergency room? Where do you draw the line? What about out of hospital cardiac arrests when they come in? So maybe you can just tell us how it works in your centers. Why don't you start, Mark? Would you offer in a septic shock child and in the ECPR with it for a septic shock?
I think the key thing is recognition and early recognition. So if you can get that patient on ECMO before the arrest, I think out of hospital arrest, cardiac arrest is a really challenging situation, and I don't think we have a clear answer for that. As a centre, we've made the stance that at the moment we do not offer ECMO for an out of hospital cardiac arrest in paediatrics. We have gone on ECMO in our emergency room in a resus situation with ongoing CPR, and it's not straightforward. So I think it's really challenging. I think that's another reason to sim and train in unusual situations. We've gone on ECMO in a resus situation, cardiac arrest situation in our neonatal unit, for example, and it's a real challenge in a different environment. So thinking outside the box as to where you train, it's focusing on this answer. I think if the patient comes in and is rapidly escalating, then I would rapidly deploy ECMO. I know we've done it before. Either you take the team down to ER or you move the team up to your area where you cannulate in your hospital. In our situation, that would usually be in intensive care. So yes, we have done it. Yes, we will do it. Out of hospital cardiac arrest, I would suggest is a different kettle of fish at the moment for pediatrics. Yeah,
for us, that's an excellent point also, where if you do it in the ER where you have not the environment, our policy in the hospital is, for example, we would go under conventional CPR to the ICU where all the people know the environment, we have all the necessary stuff, instead of getting all the equipment rolled down and do it in an unfamiliar environment. So this patient who arrests in the emergency room gets in seconds up into the ICU where people are making already the calls, they're bringing already the equipment on, and so it's a much more controlled environment. So that's, yeah.
I think kind of the same thing for us. I think if you know the patient, you've worked out your candidacy, you're prepared. I think those unexpected patients that arrive all of a sudden or arrest somewhere else in the hospital, we have deployed ECPR for those patients, but sometimes that gives you do the emergency part, you keep life going, and then you make your decisions about where you can go after that. And I think once everybody is clear with that's what you're doing, it brings everybody on board.
Yeah, and I agree with Mark and Maura. Out of hospital, we do not offer. In hospital, we have done in all forms of settings. However, there'll always be some patient where you're not prepared and you deploy ECPR, and then you may realize it was not the best decision. But the key thing there is, do we learn something from that experience? It's not always possible to predict the outcome. Sometimes we succeed, sometimes we realize it was a bad mistake, but we need to learn. I think that's a key element here. We did not repeat the same thing again.
And I need to take you up on this, Ajay. This is a very good example you just made. We don't always know the outcome, but sometimes we just make the decision to go on, and then we have to see, maybe we did something good. We gave the family time to say goodbye instead of, because the patient is on ECMO, and we can do the withdrawal in an organized way, or maybe even give the family the chance of the decision for organ donation and doing something useful in the death. So I think it's not not always bad, or the outcome is just measured on survival, and because these are things we cannot measure. How much could we do in organ donation? How much could we do for families to say goodbye, to have a death in a more controlled and comfortable way.
Yeah, we can facilitate compassionate death.
Yeah.
Yeah.
Tim and Pete.
I think we need to round it off, but Tim, do you have you had a comment?
Yeah, I was just going to add that, you know, our population is different to the adult population in terms of who arrests, and whilst the adults, you know, on the back of their trials have got a good Delphi consensus for who is a good candidate for them, and you know they're, you know, a grown up walking around with an out of hospital cardiac arrest with good, effective, uninterrupted CPR with a Lucas device, you know, straight into whatever intervention they need, cannulation intervention. That's often not the case with us, and actually, you know, most of ours are, as we know, will be, you know, receiving intensive care at the time. But for me, it's much easier to say who isn't a good candidate or who we should stop on. And I think being clear about what your stop points are is much easier than saying who we shouldn't try, and trying to rationalize that. So either you do or you don't, but you should be clear about when you're overstepping the mark. I think is probably the easiest thing to get people to agree on anyway.
Well, thank you very much. I think this has been very interesting, and I think we can talk about it for a long time and still. And I think there are two ways of doing that. One is, Mark, can you share the QR code again? Because I think if people are interested in this, they should really join the working group and work together with these people and contribute, but also learn from each other. So if Mark can share his QR code, then you can join that. And the other thing is, try and join us for the EuroELSO meeting in April in Milan to continue learning about ECMO in general, but ECPR specifically. Also, there's enough availability there. So we'll end this by thanking all the panelists and all the speakers for their excellent contributions and their discussion. And I want to thank the audience for being here and putting in these nice and important questions. And we'll keep working on them together and try to answer as many questions as we can. Please join the working group and come and join us at ELSO. But for now, thank you all very much for being here, and I wish you all a pleasant evening.
Thank you so much. Thank you.
Thanks, everyone. Take care.
Bye.
Right.